we came up with this idea that we're bringing historical trauma researchers together, clinicians, community leaders, a lot of different people together, and what we do at the Clinical Trials Network is develop and test evidence-based treatments. So the question we wanted to spend some time at this conference asking is exactly how might we go about making progress in terms of this. And so I just wanted to open up with a couple of remarks. And the thing I wanted to sort of say is first is, it's very tempting to kind of walk away from the process altogether. And in fact, we've been working for the past year with other nodes. They're called nodes in the Clinical Trials Network, the Pacific Northwest node at the University of Washington and the Oregon-Hawaii node at the Oregon Health Sciences campus. And actually with the Ohio Valley node as well, where they've been going to Native American communities and trying to establish relationships and do research in Native American communities. And as you can imagine, there's a lot of controversies regarding that. Oh, should I just walk away like this? Can you still hear me like that? Yep. You know, the other thing people might do is if you could just, since we don't want to drown out what's in the other room, if you could just, everybody, try to move up all the way to the front, that would be much more useful. Yeah, that's fine. All right. So first I just wanted to have, can everybody hear me all right? And everybody, could you just come forward? That'll make it a lot easier. How's that? Okay. Can everybody still hear me? Okay. So, basically, let me just kind of give some overview about what I mean by doing an evidence-based treatment. Now, there's been a lot of talk about evidence-based treatment. And let me just say, so some objectives are to discuss how to navigate through the research infrastructure to conduct evidence-based treatments for substance use disorders and historical trauma, to review research designs and approaches for developing an evidence-based practice or treatment, to build collaborations, and to discuss where to go next. Those are some of the objectives that we can have today, again, being kind of informal about this. So what's the state of affairs? Now, we can argue the state of affairs, and we can talk about the fact that this evidence-based practice movement right now, that you have to use evidence-based practices to get funded, may not be fair. I think we all could agree that this may not be the best state of affairs, but considering this state of affairs, I think the question I wanted to focus on was, what do we do about it? What could we do about it? One thing that's good to do about it that I'll throw out there is you could go to policymakers and you could change it. But that isn't really our goal here today as NIDA clinical trials researchers. What we're interested in is talking about, well, considering that's the climate, how can we kind of meet this demand? How can we meet the demand to create an evidence-based practice and also perhaps incorporate historical trauma? That's the question. Another kind of state of the affairs that we know is evidence-based practices may not be available for all communities of racial and ethnic minorities, especially for Native Americans. So there might be this call for evidence-based treatments and practices, but there may not be cultural competent treatments for them. It's as if the culture, as Nelson, Jim, and others have pointed out to us, it's as if the cultural competence movement kind of went in parallel with the evidence-based practice movement, and they didn't connect. That's kind of the state of affairs. So we have this gap that exists between what is available and what's needed. Now, my point in bringing this up is we'll just acknowledge that. That's the state of affairs. It may not be the best state of affairs, but that's the state of affairs. That's the context in which there's this need to develop evidence-based treatments and practices. And as clinical trials researchers, the question that we can ask is, how are we going to go about doing that? So, I pose this question, what strategies can actually be used? I mean, this is a provocative question. What can actually be done? Not what we might want to do or what could we do had we lived in an ideal world. If we lived in an ideal world, we can all admit probably that a grassroots approach should be used. You know, it should be that we take evidence-based, we take practices that are done in the community, develop them into evidence-based practices, and there should be unlimited research funds to carry that out. But in fact, that may not be the state of affairs. So we have to kind of come to this compromise between, well, what are we going to do considering that you need to kind of get research funds to develop an evidence-based practice? How are we going to go about doing that? That's a question to ask. The other thing that you might need to do is you might need to get serious, senior experienced researchers to collaborate in this endeavor. You might have to get people who know how to do research to help out. Many people that I've met, even like students, kind of take this attitude of, can't I just go out and do a research study and make it happen? Well, sometimes it doesn't work that way. You need some guidance on how to do that. And as we know, there aren't as many senior level racial ethnic minorities who are out there to advise on how to develop an evidence-based treatment. Not only is there a shortage of clinicians, there's also a shortage of researchers who are ethnic and racial minorities. So also, funding these days may be limited to build a treatment from the ground up. So although that might be ideal, and we can still talk about how we might do that, building a treatment from the ground up, it's not the most obvious way of doing things. So I'm just throwing that out. It may not be the most obvious approach. So developing an evidence-based practice or treatment is not easy. You can't develop an evidence-based treatment as a hobby. A lot of people go out, and you've seen this, where people have gone out and they do their own kind of treatment. They write a book, they pass it out, it's very popular, and they make the claim that it works. And that might be a good starting point to use, but that may not really be an evidence-based practice. That actually, it turned out that studies don't work the way they think they do. I mean, I've worked with students who say, can't I just go out for my dissertation and go do a little study? I'll give a treatment out, I'll measure pre and I'll measure post, and then I'll show that the treatment shows a change. Well, it actually doesn't work that way. Research is much harder than it looks. So it's not easy. Treatments, another issue is treatments, you have to entertain the idea, treatments may not actually work. That's the disappointing part about doing research that I've learned is I'd like to see all the treatments work, and I'd like to be able to show that they work. But sometimes I think a treatment may not work. And what that means is it might do something, but it may not do enough compared to some other treatment. So it's not as if you could say treatments do nothing, but they may not work as well as you think that they do. It may be difficult to demonstrate that treatments that do work actually work. As I said, how do you measure it? How do you find the right outcomes? How can you really show that something works? So if doing research were easy, this wouldn't be an issue, but since research is hard, this becomes an issue. And so to just kind of review, what's the context of the way I see it? So I'll take the blame if I get this wrong, and the senior faculty at UCSF can correct me if I'm wrong. But basically, I think a lot of times NIDA develops behavioral treatments clearly based on randomized controlled clinical trials, that behavioral treatments tend to be based on what Lisa Onken and Bruce Ronzaville have called the stages of development of psychological treatments. And so the behavioral therapies development programs, one of the programs at NIDA and the National Institute of Mental Health that maps out how you actually go about developing a treatment. So again, it's not that somebody just says, I want to make a treatment, and that's all you have to do. There are actually stages they've carefully mapped out about what they want at each stage. And so the problem in the research is always internal versus external validity. Psychological treatments are viewed as similar to medication development trials many times, where you can imagine that you've got a group of patients, you randomly assign one to one condition, another to another. You give one the active medication, you give the other placebo, and everything's the same. That kind of analogy is also kind of transferred onto the development of a psychological treatment. The notion, ideally, is that every element of the environment should be specified with the active ingredient of a psychological treatment clearly specified and tested in ideal circumstances. So, again, how do you go about doing that? You might be able to get good internal validity, but sometimes it may not apply in terms of external validity. And again, I just wanted to remind people, a lot of the times people have this misunderstanding, well, you know, from the vantage point of researchers, they have a misunderstanding that a pre-post design shows a treatment difference. and to talk about a classic introductory kind of research methods formulation, which I'm not going to go into a lot of detail, but just say that, in a textbook account of Cook and Campbell, these are the factors as to why a pre-post test, not a clinical trial, will demonstrate change, but the change can be explained away. It can be explained away by the everyday events such as school, work, or home life that just happen to people in their lives. It could be explained away that people naturally just change over time, which leads to change. It can actually be the fact that when you test somebody, you change the thing you're trying to test and it looks like change. It could be problems with the instrumentation changing over time. It can be something as basic as statistical regression, which if you show in just purely statistically, this isn't even psychological, if you have an unreliable measure when you compare time 1 to time 2, because it's unreliable, mathematically it goes down, it changes. Change can happen purely as a statistical artifact. There could be selection bias, there can be attrition. All of these things are problems and so it's not as if the focus on the randomized clinical trial is arbitrary. It really has a philosophical and scientific kind of foundation. We need to do clinical trials that are randomized because it controls for these factors. I just wanted to throw that out, that that's why researchers kind of focus so much on randomized clinical trials. So what are the stages of behavioral therapies that are used at National Institute of Drug Abuse and National Institute of Mental Health? They're outlined as stage 1, 2, and 3, and they're similar to the same stages that are used on medication development trials, phase 1, phase 2, and phase 3. Stage 1 basically is this pilot testing mode, and so people would go get a grant, for example, and first develop their treatment. They would write a manual, they would pilot test the treatment, but they also it's also expected that the mechanism of action is outlined. That what the therapist does is outlined with specific procedures of what the therapist is prescribed to do, which is what they should do, and proscribed to do what they shouldn't do. That's done in the first stage. So after that stage is done, to just make it concrete, the researcher then goes and asks for a stage 2 grant, a randomized controlled clinical trial, to establish efficacy, to show maybe under more ideal circumstances yet, whether or not there is a causal difference between one intervention versus not. Now at this stage, there's all kinds of issues to consider. What do you use for a control condition? If you merely used a waitlist control condition, researchers tend not to accept that because it could just be spending time with your client helps them. So how do you know whether or not the effect or active ingredient is specific to your treatment? How do you know it's not just something in the background? So you can talk about this issue of what do you use for a control condition. That's not clear. Finally, in stage 3, that's what we do in the Clinical Trials Network. We go to real-life clinical settings across the United States in multiple sites and test the intervention out. So I bring this up just to point out that there's tradition in clinical research. There's sort of expectations in clinical research. So when you go about trying to make an intervention, whether you like it or not, it's kind of like a campaign. You have to go and convince everybody along the way that you're doing the steps they want. Now, they hold the purse strings. They can say, you either do it in my way or a variant of my way, or you don't need to do it at all. Okay? So I'm just bringing this up as a researcher can be very frustrated in terms of how do you meet these expectations and get the research done. Now, I just wanted to say there's 2 ways that you could do research. There's a top-down approach or a bottom-up approach. And to just bring out some examples that I've seen, a top-down approach could just be to modify an existing evidence-based treatment. I think Maria kind of referred to it as like, well, you can take a treatment and you can just kind of add something to it, like we did some historical trauma discussion. And some of the treatments, such as Kamala Venner's work on motivational interviewing for Native Americans, she's at the University of New Mexico, there are chapters in her treatment manual for motivational interviewing about historical trauma where it's discussed. And so you could say, well, one approach is to test an existing treatment by adding the topic in there. Now, that's not ideal, but that's one approach. Another approach, of course, that I've said, is the bottom-up grassroots approach. We can build an evidence base for an existing treatment used in Native American communities, but again, it costs money to do that. We would have to somehow find the money to do that. That's the question that we have to ask. I wanted to just also talk about, well, maybe there's other possibilities here. There's other possible research designs. One I've outlined, which is the behavioral therapies development approach. Traditional, have manuals, have process measures. That's one approach, but that's not the only way research is done. There's another model that I kind of see, which is called the services research model. In services research, the way research is done is the active ingredients and the mechanisms of the intervention aren't always specified. And the question is whether or not the units of service produce a change. So it may be possible, and I'm not saying I know this, but it may be possible to do research on an intervention and just argue that the increment in service use leads to a change. And maybe that would be a way to get evidence. That's not as ideal. I don't know how that would work, but I think there are studies that are out there that do that, and that's a possibility, such as, for example, many times some case management studies that are done don't necessarily talk about all the different case management interventions that a counselor might do, but yet those studies get done and published and so on. Just one final design, and not that this is exhaustive, but just one final design, which I call the facilitation group intervention. In the clinical trials network, for example, they're doing a study or designing a study right now on 12-step programs. Well, the counselors don't deliver a 12-step intervention per se, but the purpose is to facilitate clients to sign up for 12-step groups. So the intervention is to facilitate something that goes on instead. So you could think about traditional Native American treatments as existing in addition, and that your manual guided intervention is just to get them to attend those treatments and show that that works. It's kind of an indirect way of showing evidence. So I just wanted to throw that out for food for thought, 3 possible designs. And then I'm going to open it up, like discussion questions, and to just get the ball rolling. Now what I'll do next is I think I'll let Maria come up here and maybe give her thoughts, and then invite other people if they want to come up and say what either talk about some of these issues or some other issues. But what are the possibilities? I mean, what do we manual guide? What traditional psychotherapy studies, again, outline each specific client interaction. Guidelines, these are guidelines of what is and what is not the treatment under investigation, what is the active ingredient, what isn't. Outline the mechanism of change and delineate what an example is of what you do and what you don't do. So for example, those of you who've been taking some motivational interviewing classes, you might have realized that, well, a confrontational approach is usually not seen as the ideal way to do motivational interviewing. A more humanistic, existential kind of interaction is. Those are the kinds of examples that a manual would say to do or not. Well, the question is, what do we manual guide? Some things we may not be able to manual guide, or we may not want to. Comes up with issues such as what Nelson talked about, ownership. Who would own it then? Maybe we don't want to do that, but that's a question. Another issue is, how do we define success, quote, success? We could talk about reductions in psychological stress. We could talk about dropout from the treatment program. We could talk about reduction in alcohol and substance use. There might be other kinds of variables we want to look at, and we have to kind of consider those kinds of questions. So I want to just end with suggestions. What kinds of treatments can be tested in using conventional research design? On the other hand, what kinds of treatments can be tested in alternative designs? And what might these alternative research methods be? I think that one thing interesting to kind of build on what Joe Gahn's talk was is sometimes there might be a stereotype that science only proceeds in one way, in the most reductionistic way. But sometimes science can proceed in other ways. I'll tell a joke, a kind of a funny story if you don't mind. When I was in graduate school, one of my professors won an award from the American Psychological Association called, I think it was called the Henry Murray Award. And Henry Murray, director of the Harvard Psychological Clinic, said, you should use tough and tender methods both tough and tender. And I brought my friend with me, who was an experimental psychologist, and he said, tough and tender methods? What kind of tough and tender, what tough methods do you use in clinical psychology? The kinds of methods you use is you have some clinician look at a client and you do a rating scale. I mean, the idea here is the tough methods that we talk about sometimes really don't have to be that tough. They can actually be as kind of loose as I had a clinician who is familiar with the Native American culture see a client and judge on some outcome, a change. And as long as I trained other Native American observers to match up and show inter-rater reliability, perhaps I've gotten a valid way to do measurement. So you can find compromises. You can find compromises between traditional scientific ideas and something that will work. And so that's the challenge. So we can either walk away, which I don't think we want to do, or we can think creatively and figure out how can we actually come up with evidence, build the evidence and make progress. So thank you.
I think for me the easiest thing to do is to share a little bit of my experience with approaching to getting funding, and IMH funding specifically, and backing up to what my motivation was to alleviate the suffering of our people. I want our people to feel better. That's, and in terms of as far as what can be measured, which was an earlier thing in terms of outcome. So a reduction in distress certainly would be something that people feel better, they feel empowered, and our people reclaim our sense of who we are and our traditional sense of self, and a healthy return to a lot of our own ways of healing. That's ideally what I would like to see. So when I started out in terms of the first historical trauma intervention in 1992, we went through a series that was a 4-day experience, psychoeducational, some refer to it as that. There was opportunities for small and large group processing, lots of audio, we have interference there, lots of audio visual use of materials, educating our people more about the historical trauma and the effects of grief and trauma on our people, talking about our traditional culture, our traditional values, sort of reconnecting people with that. We also had a lot of humor. We had a talent night. People were contained because we did the pre-test, post-test design, but this was a dissertation. This was dissertation research. So, and I went to a clinical school for my doctorate, which was Smith's. So there was this whole integration. Then we had a NEPI, a purification lodge. We had a Lawampi, a healing ceremony, like the third day. So it's like, well, what was the thing that caused the healing? You can't reduce it like that because it was sort of a package, and there are many elements of that. So that's one of the challenges in terms of research. But it is important to think about that. So then I was trying for a number of years to just find funding to just do that, and was meeting quite a few obstacles. SAMHSA was actually a good vehicle because they're not the National Institutes of Health, and they had more leeway, and this was before they started to require everybody to embrace an evidence-based practice. And when we got the funding from the community, CMHS under SAMHSA, Center for Mental Health Services, that was under I mentioned under special minority initiative, and you did have to propose a model that you used, and you had to substantiate it. And they accepted the historical trauma intervention as being an evidenced, I can't remember what was called, evidence-based practice model, I think is what they called it, or something. It wasn't quite on the registry yet, but that was fine in this special initiative because we had some data on it. There was some publication about the effectiveness, although it doesn't meet the scientific rigor of NIMH. So at this point, where I'm at is at that pilot study, that stage 1 level that Dr. Shire talked about, and that is the funding mechanism is called an R34, which is to get pilot data. There's also R21s, which are for exploratory research data. And the unit or the branch of NIMH that I'm applying to is a services research branch. So that's good news, because they're not so concerned that in the more strict clinical intervention research funding is really concerned with maybe focusing only on one disorder. And I'm saying, no, you can't do that. There's depression, and there's PTSD, and there's other anxiety disorders, you know, in terms of the clinical frame or the clinical lingo, and there's the grief. And you can't, it's hard to separate that out because those are all issues for our community. So they're not so concerned about that, is what I understand at this point. And so that's the good news. The thing is that they won't fund historical trauma intervention by itself outright because it doesn't have enough evidence base. As, you know, as we've talked about today, there are problems with that. So the only way, and I fought this for years, the only way to do this in my situation is to partner it, combine it, blend it with another evidence-based model or empirically supported treatment that NIMH has funded. So there are two options. One was interpersonal psychotherapy, which has some evidence base and some funding. There's also cognitive behavioral therapy. I mean, that's another option, but I was looking at interpersonal psychotherapy and complicated grief treatment. However, there's not a lot, but NIMH has funded a couple of complicated grief treatment studies, which is now called prolonged grief. And there's one R01 that's just underway at Columbia with older adults. But the route that I'm going to go is sort of it's trauma, grief, and loss. And what I'm going to do is have a whole historical trauma component, take key components from the historical trauma intervention, put those first so people are grounded in that, then do some of the regular grief-focused interpersonal psychotherapy sessions, and then intermittently intersperse certain things that pull people back into the more cultural issues. And then, and as we can, include the spiritual practices, offer that to clients. Now what's interesting is this is going to be an individual-based model, which is different because my work's been group-focused. But it's a reality that a lot of people in the field and clinicians are working with people one-on-one, and they need something to do for people who are seeing them one-on-one. So I'm thinking about how to give people sort of the same kind of an experience as with the group. So we're working on using pieces of the Takini Network video and a kind of a DVD that can be used that would give people some kind of semblance of a group experience, even though they're being seen individually. So those are some of the things that I've been working on and playing with as ideas for tackling things that Dr. Shropshire really outlined well in terms of the challenges of research. So the other thing is I think that involvement of the community is critical in all of this, and we have that track record of already having done that, but we have not just a cultural advisory panel lined up, but it comes out of a lot of immersion and support and endorsement from our community, or indigenous communities kind of on a broader level. So I think that that's really, really important. I think that I'll stop there and see what other comments. I'm amazingly tracking okay, I think, because I got in real late last night and I didn't get too much sleep. So, but I did have coffee earlier, so that helped.
I haven't had my cup of coffee, so. Though that's an excellent question, and as you were asking it, and as Maria and others have been talking, I've been struggling with a couple of things around. And I think, Joe, you tapped on this too, in terms of what is out there in terms of just the reality is we're working in Western institutions quite often in urban settings with expectations around particular sets of models that we have to be operating from, yet we have a strong desire to reconnect to the earth, the sky, and our appropriate traditions. And I think Joe was posing this question throughout the day is, you know, how do you really wed those, or do we? Is it even appropriate to try to wed those things? So I'm floating around with some of that. I think that, let me tell you what I've done a little bit and how I struggle with all of this. Maybe that may not be helpful, but I hope it does a little bit. This is in terms of when I first applied to National Institute of Health. In my very first grant, I said that colonization has a negative effect on Native people, and the review came back saying that there's no evidence that colonization has hurt our people. And so that's where I started from. So that was that would have been 1995, 97, right around that period, 97 I think it was. They've come, actually, they've moved, and for better or for worse, they've moved in some directions. And now, just last year, 2 years ago, an RFA came out from National Institute of Health for cooperative agreements with tribes. And this is actually really, really important. You guys might not be aware of this, but they're called, they're U mechanisms. They're UO1s. And what that does, and also the NARCH grants are similar. What it does is, it says that you are creating a cooperative agreement. It's a tripartite agreement between the tribe, the National Institute of Health, and if the tribe so desires, a university or research institution that helps to facilitate their interests and their questions. In this particular mechanism, and it's the only time I've seen it, they actually said that the tribe should belong to the data should belong to the tribes. And so we actually have developed out of this mechanism, this is for a study on cardiovascular disease prevention that we're currently developing with the Tulalip tribes up in the Northwest. And we are currently doing a data sharing agreement with the tribes where based on there are different models out there. Navajo Nation has their own, but a lot of tribes don't have their own institutional review boards. They're not set up to be able to do this. So it becomes the burden on the researcher and the community to figure something out. And so I strongly encourage people to look at NCAI's website, their research policy website. They give a number of examples of data sharing agreements. The indigenous peoples on biocolonialism have something called the Indigenous Research Protection Act, which actually specifies everything from tribal ownership around data to genetic materials and the whole 9 yards. So there are models out there from our communities, and the communities are becoming empowered. And I would actually argue that that's part of decolonizing and getting rid of the historical trauma. So there are some models to look at. But that doesn't address the other underlying issue is how do we really look at these, how do we integrate these models, traditional models, into our approaches. And I'm similar with Maria. One of the things that we've struggled with in developing the cardiovascular disease intervention is how do we understand historical trauma related to food. I mean, if you think about food and diabetes, it's a no-brainer from a Native perspective, right? Reservations, commodity foods, you wonder why we're obese and having a lot of difficulties. So one of the first things we did is we said, well, we didn't want to just do an intervention. We also wanted to do a qualitative study to get the narratives from the community's point of view about how they understand their traditional and original instructions in their relationship to food. And out of that, we're trying to create a community-wide intervention eventually about getting through kind of the interruptions that have happened tribally in that relationship between food and activity. But what we did simultaneous to that is we're also developing an intervention on an individual level. So we're doing an intervention that looks at starting with a group, working with a group and integrating the historical trauma elements in it from the qualitative interviews with the elders and the leaders. And then we're moving from that group level intervention to a one-on-one 4-session motivational interviewing. It's going to sound a little bit like a hodgepodge because it is right now, but we're working on it. And that 4-session intervention, like a lot of people acknowledge today, that's very limited. That gets us a little piece of it. But the idea was that we wanted to start where families are realistically at. Increasing exercise is not a lot of families' number one priority. If their kids are struggling in school, the grandparents aren't available to help support. I mean, there's a lot of other life issues other than exercising in that week. So we thought, let's look at the motivational interviewing piece and set some realistic goals for a family about changing some behaviors. Then from there, we moved to buddy peer support intervention that lasts for 6 months. The idea is we're going group, down to individual, short individual intervention, back up to a dyadic intervention that provides social, affirmational, emotional, spiritual support. And then from there we move back to a group intervention where we're looking at the Res Chef model that's currently being done. So the families are actually going to create their best recipes, and we're integrating the best recipes used from elders that people really love in the community. And they're creating their own talk show called like Res Chef, and it's going to be broadcast on their cable network. So I think we get ourselves locked into not being creative when we just think about only an individual intervention. We have to start thinking about multiple level, multi-systemic interventions that would resonate with us. Now, in terms of spirituality and traditional health and healing components, I'm going to make an interesting argument, and I've been really struggling with this. I think I worry when we use the word cultural competence because I don't think it's appropriate for everybody to be competent in traditional health and healing practices. I think we walk a dangerous line when we start prescribing. I don't want someone to run around and say, I've got a manual to run sweat lodges and I'm going to go run a sweat lodge. That's my fear. And I don't know that we should subject some of our traditions to empirical testing, because I think the empirical testing lacks the robustness to understand what the spirit is and the medicine's really about. I don't think that they're two different worlds. So if you don't show an effect or a large enough effect size of a sweat lodge ceremony, does that all of a sudden now not become an efficacious way of healing for the community? I don't think that's open to question, really, for a community and a people. So I'd be very careful about subjecting some of those things to any kinds of testing. But it doesn't mean that you can't incorporate spiritual healing or traditional health providers in the interventions we develop. It's just we need to be really, and I think I'm arguing to the converted, but I think we just need to be really mindful and careful about how we do that. And certainly I think about it with substance abuse. I mean, a lot of our community that says that they're doing well is because they're going to Native American church and because they're participating in purification ceremonies or Sundance ceremonies, or they've committed to a sober way of life so that they can, or the Red Road, they're following a certain path. And to look at that in other kinds of ways around historical trauma, I think you might want to ask, how are people spiritually taking care of themselves? How are they engaging in healthy, everyday health practices to keep themselves well? Those are some of the questions we can be looking at. How does participation in ceremony increase people's sense of wellness? Those are the questions we ask in a lot of our studies.